8, 9 questions for you.
Okay.
So already. So in any case, we'll hear Rashmin, a pioneer and one of the last words in neuro-ophthalmology, to tell us what everybody should know and should not miss in optic neuritis. Over to you, Rashmin.
Thank you so much, sir. And I thank Dr. Lalit Verma and the entire team for involving me in such a very, very interesting concept. So the theme of the webinar is what we should know and what we should not miss. So let me walk you through a patient and let's discuss as to what are the things that a comprehensive ophthalmologist should be aware of if he's dealing with this kind of patient. So this is a story of a 42-year-old female who comes to you with an acute loss of vision in the left eye, and her visual acuity is by 60 in the affected eye. The other eye is normal. She demonstrates relative afferent pupillary defect in the left eye. The right eye fundus and the fields are normal. And this is how her left eye disc looks like. And as you see, she has a florid disc edema with hemorrhages on the surface of the disc. So the first question that we'll ask as an ophthalmologist is what kind of optic neuropathy she is having. In a 42-year-old female with an acute loss of vision, two commonest optic neuropathy would be optic neuritis and non-arthritic anti-ischemic optic neuropathy. So the first step would be to say, how do we differentiate between these two? How do we confirm that patient is really having optic neuritis and not an ischemic? And what would help you would be the history, the examination of pupils and color vision, the appearance of disc, and the fellow traveler. In an optic neuritis, generally there'll be an acute loss of vision. Vision stays there or continues to go down for around 2 weeks. And after the onset of symptoms, after 2 weeks of the onset of the symptoms, the vision will start improving. And by 6 to 8 weeks, in a typical optic neuritis, vision will come back to normal. In contrast, in anterior ischemic optic neuropathy, vision will go down, and in 75% patients, the vision will stay there. In around 1/4 of the patients, there can be little increase or decrease of the vision in non-arthritic anti-ischemic optic neuropathy, and that depends upon the patient's, the status of vasculopathic risk factors, and in some cases, even the patient's renal function test. So that gives you a clue whether you are really dealing with optic neuritis. The other indicator that you might be dealing with optic neuritis and not any other pathology would be color vision. In optic neuritis, the color vision loss would be much more or disproportionately more than the Snellen's visual acuity loss, while in ischemia, both these would be parallel. Disc appearance, in a typical optic neuritis, when I say typical optic neuritis, the optic neuritis which has been described in one of the largest trials which was done in optic neuritis, which is ONTT, and there up to 70 to 72% of the patients had retrobulbar neuritis, the disc appearance. While AIOL, you will always a disc edema, which can be a sectoral disc edema, and you'll find that the other eye will have a small disc with a small cup, or what is described as disc at risk. Fellow travelers, in ischemic optic neuropathy, you will always have a vasculopathic risk factor or hyperhomocystinemia, while in optic neuritis, you may either have pain on movement, or you may have even a neurological symptoms like paraparesis or difficulty in maturation if patient has associated neurological disorder. So this is how, if you see a patient with an acute loss of vision, the first thing is to differentiate between optic neuritis and AIOL in most instances. The second step, so this is what we should know, that two commonest optic neuropathy in an acute loss of vision are inflammation and ischemia. There are other causes, but they are rare. Now, what we should not miss if you see a patient, and if we have determined that now the patient has optic neuritis, which is the topic of focus for today's webinar, the second point we should not miss is that, is it a typical optic neuritis or atypical optic neuritis? Typical optic neuritis is what was described in ONTT, generally associated with multiple sclerosis, while atypical optic neuritis generally would be other immune-mediated disorders like sarcoidosis, or two disorders which are now gaining momentum, especially in India and Asia, are NMO, neuromyelitis optica, and MOG. Now, these two are the names of the antibodies which can present with optic neuritis. Now, why it is important to differentiate between atypical and atypical is because the diagnosis or the neuroimaging that you order for, what you look for in neuroimaging are different. The treatment is different and the prognosis is different. And in some instances, a treatment for one, if instituted for the other, if you institute a treatment for typical optic neuritis to prevent multiple sclerosis, you might end up harming the patient if the patient actually has an atypical optic neuritis. So that's the reason why we should not miss a presence of atypical optic neuritis. So when do we suspect that the patient has optic neuritis, but it might be an atypical optic neuritis? First is absence of pain. Now, ONTT, 90% of the patient complained of pain. A similar study done in India, the patient coming back with a history of pain was a little less. Now, that can be probably attributed even to our threshold of pain tolerance. Presence of disc edema, again, as I said, 70% of the patient in ONTT, which is the study which defined typical optic neuritis, did not have a disc edema. While in our patients, we may have a little more disc edema, but presence of disc edema should always alert you that maybe you are dealing with atypical form of optic neuritis. Bilateral presentation, simultaneous or within a day, a couple of days, should always alert you to atypical optic neuritis. It is almost never seen in typical optic neuritis. And if patient has a bilateral presentation, our complete gamut of investigation changes. Severe loss of vision, no PL or a PR inaccurate kind of vision on presentation, it can happen in even typical optic neuritis, but we should be alert for presence of atypical optic neuritis. Complete lack or partial response to steroids. Recurrence can occur even in typical optic neuritis or MS-associated optic neuritis, but recurrence with loss of vision or lack of response to steroids should alert you towards atypical optic neuritis. So now, the first step was, is it really optic neuritis? Second step was, when do we suspect atypical optic neuritis? What investigation we should order? And this is very important because all this is what we should do and then involve neurologists, because neurologists would not have an access to a good fundus examination or all these investigations. Visual fields is must for both the eyes. If the eye which has an attack has a profound visual impairment, you may not be able to perform formal fields, but when possible, visual field for both the eyes. The visual field that I'll order would be HVF 30-2. OCT again is gaining a momentum as a part of investigative tool in any optic neuropathy. There are controversies surrounding OCT, role of OCT, but it has some role in the investigative modality for optic neuritis. In multiple sclerosis, you might find that there is a RNFL thinning even in an eye which has not had an attack of optic neuritis. OCT is also useful to partly differentiate between optic neuritis because of multiple sclerosis and optic neuritis which occurs in neuromyelitis optica. Neuroimaging, please remember, CT scan has no role in the management of optic neuritis. It does not really tell you much except that it rules out the presence of compressive lesion. It does not guide you towards the diagnosis or management of optic neuritis. The investigation of choice is always MRI. And in MRI, the investigation that we have to request for is MRI brain and orbit with contrast. It might be a good idea to alert a radiologist that you are suspecting optic neuritis. He will then institute a suitable sequence like fat suppression. So neuroimaging, MRI brain and orbit with contrast always. In the olden days, we used to say that MRI is necessary only for prognostication in patients with optic neuritis. It does not really help you. If you do MRI and if you find a brain lesion, you know that that patient is at a higher risk of developing a neurological deficit of multiple sclerosis. And that was the role of MRI, let's say 5 or 10 years ago. But now I would recommend that MRI should be requested for in all the patients with optic neuritis. And I'll come to the reason in the next slide. Role of blood tests, if the patient had a loss of vision and it is improving, then the blood test may not give you any extra information. Otherwise, the blood test would be to rule out concurrent infection, or in the cases where you suspect infectious optic neuritis, the other blood test would be to know the presence of aquaporin 4 antibody or NMO antibody. Electrophysiology had a major role to play in pre-MRI era in the management of optic neuritis. Now the role of electrophysiology or VEP would be only when you are not very sure whether patient really has an optic nerve problem or whether patient is malingering. And in a rare event where you are not really able to differentiate between ischemia and optic neuritis, VEP may be an adjuvant, but it does not have a major role to play in the management or investigation of optic neuritis. So we should know about these investigations. Now, what you're looking for in HVF, the commonest visual field defect in optic neuritis is generalized reduction of sensitivity or central or centrocecal scotomas. Please remember, even optic neuritis can demonstrate altitudinal visual field defect, though it is more commonly described with AION, but even in ONTT, altitudinal visual field defect was fairly common. So presence of altitudinal visual field defect does not rule out optic neuritis. As you mentioned, OCT, RNFL thickness of 41 micron and a diffuse RNFL loss on OCT is highly suggestive of neuromyelitis optica, while in a typical optic neuritis, at least in the initial phase, there will be an RNFL loss mainly in the temporal area. Presence of RNFL loss after an acute phase is over also predicts the future disability. So OCT is gaining momentum in the management of optic neuritis. As I mentioned, MRI, and what we are looking for now is what are the features that you are looking for. If patient comes back to you with MRI report, what you should look for is whether chiasm and optic tract is involved. If apart from optic nerve, if there are lesions in chiasm and optic tract, you're probably looking at neuromyelitis optica. If you have an optic nerve lesion which is restricted to one segment, you're probably looking at optic neuritis of multiple sclerosis. But if whole of optic nerve is involved in the orbit, then you are looking at neuromyelitis optica. And that's the reason I said that MRI is important. Now, looking at MRI, you will be able to predict whether this patient is likely to be typical optic neuritis or optic neuritis associated with multiple sclerosis or optic neuritis associated with neuromyelitis optica or MOG. Now, these two are very important to know because if it is going towards NOB, NMO is an aggressive disease. It causes recurrence, it causes very fast neuronal loss, and it also causes within 1 year more than or close to half of the patient may develop paraplegia. And they are the people who come to us on day 0. So when the patient develops an optic neuritis, we still don't know whether he's going to go towards NMO. And these are the features which will tell you that, oh, we are suspecting NMO. And that's where you act fast and institute treatment, which we'll look for. So if you see an MRI report, look for how much of the optic nerve is involved, whether chiasm and optic tract is involved, even in the brain. The areas which are involved in NMO are completely different from multiple sclerosis. Typically, if you find a white lesion in dorsal midbrain, especially area postrema, is where you know that you are most likely dealing with NMO. And these are the patients who also will have hiccups and nausea. This is just to demonstrate this is what you're looking for. This is an MRI of a patient with NMO who had a aquaporin 4 antibody in his blood. And you see that whole of the optic nerve here is lit up, and so is chiasm. This image I've taken from American Journal of Neuroradiology, again to demonstrate the areas which are involved in NMO, which are not involved in MS. Like here, you see that there is medullary involvement, thalamus involvement. So in other words, NMO, you can also ask for other history when you look at these patients, whether patient had weakness of legs, arms, loss of sensation, vomiting, hiccups, or bladder or bowel dysfunction. So what should we know? If you are suspecting NMO, what at this point in time, in most instances, a neurologist would have come in the picture, or neuro-ophthalmologist would have come in the picture. And what they will do is ask for a blood test, which is aquaporin 4 antibody or NMO IgG test. The NMO is also associated with other immune-mediated disorder, so a blood test for like C-ANCA, P-ANCA, and in most instances, we'll also ask for lumbar puncture. In lumbar puncture, a neurologist is looking for presence of WBC, which is seen in higher concentration of WBC is seen in a lot of these patients with NMO. They'll may also look for oligoclonal bands and presence of other inflammatory markers or presence of infection. What should we know about the treatment as a general ophthalmologist? As I said, these patients come to us first, and these disorders, atypical optic neuritis, especially NMO associated disorders, or what is also called NMO spectrum disorders, are extremely aggressive. And we should know that all these patients should get IV steroids as soon as possible. Now, this is contrary to what we learned, let's say a decade ago. A decade ago, we were told that optic neuritis in most instances is a self-limiting disease. It does not matter whether you give steroids or you don't give steroids. At the end of 6 to 8 weeks, patient will have a vision which he would anyway would have got even without steroids. That's not the case with NMO and MOG. Now it is believed that within 48 hours, you should have instituted steroids because that will help us to blunt the further recurrence, and surely it helps us to prevent or delay the onset of paraplegia. A lot of neuro-ophthalmologists now are going for plasma exchange very early in the management of neuromyelitis optica. The reason being, it's an aggressive disorder. So if patient, and I'll summarize and tell you that what are the features which suggest that this patient would require a very aggressive treatment apart from steroids. A chronic maintenance therapy would be required for a very long time in these atypical optic neuritis associated with neuromyelitis optica. Generally, neurologists, and this is all in the realm of neurologists, but just for knowledge sake, that azathioprine, mycophenolate, or rituximab are the immunosuppressive agent which are typically given for longer period of time. The good news is that there are newer drugs like tocilizumab or eculizumab, which has been proven effective to prevent paraparesis in patients who have positive echoporin 4 antibody in their blood. A similar disorder like NMO, which again we are seeing more and more in India, is MOG, which is again antibody to MOG, which is a similar spectrum. Like they also have optic neuritis and transverse myelitis, but they have more association with encephalitis. It is much more bilateral. It is more likely to be, so MOG antibody, if you find a MOG antibody in the blood, you know that patient is going to do well as far as the vision is concerned, because the recurrence rate is much lower in MOG versus NMO. It has a better recovery. And how do we clinically say that this patient will require a blood testing for MOG? Is when you look at MRI, you'll find that in MOG, patient associated with MOG neuritis will have what is called as perineuritis. There's inflammation around the axons of the optic nerve, which might actually spill over in the orbit. And interestingly, a lot of patients who are patients who are COVID positive have demonstrated optic neuritis with MOG positivity. So there is something happening there. All these patients will require early treatment and chronic immunosuppression. Again, NMO and MOG, other important things to know is that in a typical optic neuritis who might be going towards MS, typically neurologists will give them interferon. While if interferon is instituted in NMO or MOG, actually it will increase the recurrence and patient will do very badly. So that's again a reason why role of ophthalmologist and neuro-ophthalmologist comes in, that you might have to inform the neurologist that we are suspecting these two, and accordingly he will treat. He'll make sure that the immunomodulators like interferon are not given if you're suspecting NMO or MOG. So to summarize, atypical optic neuritis can be immune-mediated, while a typical optic neuritis generally would have a benign course. Immune-mediated optic neuritis can have an antibody in the blood with a systemic condition or without a systemic condition. So with antibody and no systemic condition is what we are more likely to see, that is NMO and MOG related antibodies. If there are no antibodies, then you have a systemic condition like sarcoidosis, which will also have most of the time concurrent vitreous cells or even anti-uveitis, or a no systemic condition. Then you are looking at a condition called Creon. To summarize, so that was in brief what we know about optic neuritis. What should be the red flag for us? A profound loss of vision with disc edema, or if you see bilateral presentation, both eyes getting affected simultaneously or within a couple of days. MRI showing involvement of entire optic nerve or involvement of chiasm or optic tract, all these patients should be referred to neurologist early, and they should be, we should mention that all these are present so that they may look for NMO antibody in the blood, and then they institute early treatment, and they also would give immunosuppression. All these patients we should follow up and do HVF and OCT at subsequent visits. Thank you very much.